Hello everyone, thank you for joining me in this lecture. My name is Yeong from Malaysia. The topic of my presentation is Basic Principles of Targeted Radionuclide Therapy. These are the contents. I'll talk a little bit about the development in nuclear medicine, what is targeted radionuclide therapy, the principles, and the methods. And finally, I will explain a little bit on theranostics. This is a long journey of nuclear medicine development. It is always nice to look back at history to see where we came from. Nuclear medicine development can be traced back to 1890s when Henry Becquerel and Marie Curie first discovered radioactivity. In 1930, Ernest O. Lawrence, he developed the first cyclotron to produce medical radioisotopes. In 1937, Carlo Pereira and Emilio Sicker discovered technetium-99m. And in 1946, the first iodine-131 treatment was introduced by Dr. Saul Hertz, and he is recognized as the founder of nuclear medicine. 1957 is the year when the first gamma camera was introduced. It's known as Engel gamma camera, developed by Harl or Engel. And in 1958, the three scientists developed technetium-99m generator. And since then, there was a widespread use of nuclear medicine for human diagnosis. 1973, the first PET scanner was introduced, and the development continues in 1990s for therapeutic nuclear medicines with the development in radiolabeled antibodies as well as alpha particle therapy. And in the last 2 decades, we have seen multiple new terminologies come out, such as radioimmunotherapy, theranostics, molecular imaging, and therapy. And these methods are categorized and known as targeted radionuclide therapy, which is our main topic today. So what is TRT? TRT stands for targeted radionuclide therapy. In this treatment, the therapeutic agent is administered to the patient via different methods. It can be IV injection, oral, local regional, arterial, or direct intratumoral injection to deliver a lethal dose of radiation to the tumors from internal sources by targeting their specific molecular or functional targets with the agents. The local dose is delivered directly by short-range beta, Auger electrons or alpha particles, or indirectly via the bystander effect. So in simple words, the radioactive compound is linked to a targeting molecules, which will then bind to a target proteins which expressed by a specific cancer cells. So using this method, the radioactive compound will target only the specific cancer cells without damaging the surrounding healthy cells. Compared to conventional chemotherapy or external beam radiotherapy, targeted radionuclide therapy has the potential to deliver therapeutic radiation more specifically to the cancerous cells in a way that minimizes toxicity to surrounding normal tissues. And we quote the words by Paul Ehrlich, a magic bullet. And you may be aware that there are some new terminologies introduced in the last 1 or 2 decades in medicine, such as targeted therapy, targeted radionuclide therapy, theranostics, personalized medicine, molecular imaging, or molecular therapy. All these words are created in the era of precision medicine, which is the era that we are currently participating. And in fact, the concept of targeted radionuclide therapy is not new. A very classical example is iodine-131 thyroid therapy, which we have been practicing for many decades, and the first case was introduced in 1946. For example, in the iodine-131 treatment, before the treatment, we will do a pre-treatment imaging using can be the same radionuclides iodine-131 to quantify the thyroid uptake. Then we prescribe the high-dose iodine-131 to the patients, and iodine-131 will target or uptake by the thyroid glands primarily, without significant uptake in other organs. And after the treatment, we can do a post-treatment imaging to monitor the biodistributions of the iodine-131 in the whole body and to determine the treatment efficacy. And if we compare the principles of conventional external beam radiotherapy and targeted radionuclide therapy, in external beam radiotherapy, we use primarily photons and electrons in the energy of 6 to 15 MeV, whereas in targeted radionuclide therapy, we are using radioisotopes labeled with antibodies or peptides or other targeting molecules. In radiotherapy, we use low LET radiation, linear energy transfer, which is about 0.2 keV per micrometers. Whereas in targeted radionuclide therapy, it can be a mixture from low to high RET radiation, such as alpha, which is 50 to 230 keV per micrometers, beta, gamma, X-ray is 0.2 keV per micrometers, and the alpha electrons is 4 to 25 keV per micrometers. And in radiotherapy, we look at the tumor radiosensitivity as well as their microenvironment to determine the treatment regime. However, in targeted radionuclide therapy, there are some other factors that we need to consider, such as the size of the tumors, the locations, the antigens density, radiosensitivity, as well as the microenvironment. In radiotherapy, it's mostly using homogeneous irradiation field, whereas in radionuclide therapy is heterogeneous dose distribution. It can be throughout the whole body. And in radiotherapy, we use 2 gray per fractions for multiple fractions, whereas in targeted radionuclide therapy, it is more like a protected exposure, and the radiation exposure can last from hours to days. And the dose rate in radiotherapy is very high, 60 to 120 gray per hour, whereas in radionuclide therapy, we use mainly the low absorbed dose rate, which is less than 0.1 to 1 gray per hour. And in radiotherapy, the dosimetry is very well defined. We have the TPS system to plan for the treatments to the dose about 50 to 80 gray. But in radionuclide therapy, the calculation, the dosimetry is much more complicated, and this area is known as medical internal radiation dosimetry method, and it is still in the research and development stage at the moment. So now let's look at the methods of targeted radionuclide therapy. I actually classify them into 3 categories. The first method is known as radioimmunotherapy, RIT. Second method is using peptides, receptor radionuclide therapy, and the third method is the enzyme-targeted therapy. Let's look at the first method, radioimmunotherapy, RIT. Immunotherapy modulates the patient's own immune system to facilitate an anti-tumor effect. The effect is long-lasting, and the side effects are much lesser than chemotherapy. Example is using the anti-CD20 for lymphoma cells. However, the curative effect varies between individuals. So in radioimmunotherapy, we are using monoclonal antibody, which is engineered, man-made, to recognize and bind to the surface of the cancerous cells. We call it as antigens. The antibodies will mimic the antibodies naturally produced by our body's immune system to attack the invading foreign substances such as bacteria and viruses. And in this case, it's the cancerous cells. So different cancerous cells, they will have a specific antigens on the surface of the cells. And we produce the monoclonal antibody, mono meaning one. So it will only specific target to one antigen. Clonal means we cloned the antibodies in the lab. Label it with radioisotopes. So these monoclonal antibodies, once injected to the body, it will find the tumor-specific antigens and bind to it. Then the radiations will be used to kill the cancerous cells. And these are the 2 popular agents of radioimmunotherapy. The first one is known as Bexa, which is labeled with iodine-131 with an antibody called toxi-2-MAMP, but this product is no longer available on the market. It has been replaced by yttrium-90 ibri-2-MAMP, thiosectin, where the brand name is known as Zevalin. And the indication is for non-Hodgkin B-cell lymphoma, for newly diagnosed patients, and for patients who have not responded to chemotherapy or treatment with the monoclonal antibody rituximab and other subtypes of lymphoma. And this diagram shows how Zevalin works. CD20 is the receptors that often present at the B cell of the lymphoma and leukemia cells, which are the cancerous cells. So there will be many CD20 receptors on the surface of the B cells. And ibrutinib is the man-made monoclonal anti-CD20 antibody. So once it's injected to the body and circulated throughout the body, it will go and bind only to the CD20 receptors. Once it's bind to the CD20 receptors of the B cells, the beta radiation from yttrium-90 will be used to kill the cancer cells. And using this approach, the normal cells can be spared from ionizing damage. And after the success story of Zevalin, there are abundance of research carried out with all sorts of other antibodies. For example, lutetium-177 labeled with J591 for prostate cancer treatment. However, the radioimmunotherapy did not live up to the expectation, mainly because of three reasons. First, the size of the antibody, which is 10 nanometers, inhibited its movement through the biological system, resulting in slow targeting in tumors. And second, the radiopharmaceuticals, they were lingering in the bloodstream for a long time and long biological half-life. And it is difficult to find a suitable radioisotopes that having the same half-life compatible with the biological half-life of the antibody, which is typically 11 to 30 days. And then research have moved on to peptides. And that brings us the peptide receptor radionuclide therapy, in short PRRNT or PRRT. So the peptide receptor radionuclide therapy is a systemic or local regional administration of a radiopharmaceutical composed of a beta-emitting radionuclide collected to a peptide for the purpose of delivering cytotoxic radiation to a tumor. The peptides used are designed to target the cellular proteins, usually the cell surface receptors, such as the somatostatin receptor subtype 2, SSTR2. And this subclass of receptors is overexpressed in a tumor-specific pattern, thus providing specificity to the radiation delivery. So the concept is similar to radioimmunotherapy, except that now it has expanded to the cellular proteins, which can target more types of tumors and not only rely on the on-body immune systems. And the advantages of PRRNT compared to radioimmunotherapy is the somatostatin analogs have higher biological half-life, and the analogs have varying affinities to different subtypes of receptors, meaning that it can target more cancer cells. The example of the analogs is lanreotide, docetaxel, docetaxel, and the docetaxel. And the radionuclide example was yttrium-111. And recently, we have been using yttrium-90 and lutetium-177, which are the beta emitters. And recently, there are developments in actinium-225 and bismuth-213, which can emit both alpha and beta radiations. PRRT is a popular treatment for neuroendocrine tumors. Neuroendocrine tumors can spread throughout the bodies. The green dots here shows the primary site and the occurrence of neuroendocrine tumors. Bronchus 20 to 25%, pancreas 17 to 20%, small intestine, which is the most frequent site, 55%, rectum, colon less than 5%, and also other sites such as thyroid, adrenal, and the cervix or ovaries. And the metastasized sites include liver, nodule, and also bone. And the images here shows a very promising results for lutetium-177 docetaxel treatment for neuroendocrine tumors. Before the treatment, PET-CT was done using gallium-68 docetaxel. And this is post cycle 1, 2, 3, and 4. And you can see the tumors have significantly reduced after the post cycles 4. Mr. Soma will explain to you in more details about this treatment. And recently, actinium-225 as well as bismuth-213 have been introduced. Actinium-225 has the advantages of combination of various alpha and beta radiations. If you look at the complex decay scheme of actinium-225 here, on the left are the decays that contribute to different alpha particles of different energies and different decay time. Whereas on the right are the decays that contribute to beta radiations of different energies and the half-life. So using the combination of alpha and beta particles, alpha can travel up to 50 to 80 micron range, whereas beta can travel up to 1 to 10 millimeter range. This is the example of actinium-225 DOTA-TOC treatment by Yeong et al. In April 2019, you can see a huge tumors at the liver of the patient, and after the treatment, 3 months later, the PET-CT shows the tumor has significantly shrunk and the uptake is also significantly reduced. And lastly, we have enzyme-targeted radionuclide therapy. The popular treatment for prostate cancer using PSMA is an example of enzyme-targeted radionuclide therapy. PSMA stands for prostate-specific membrane antigen. It's a cell surface enzyme that is overexpressed on only the prostate cancer cells. So PSMA can be targeted using an enzyme inhibitor, which we labeled PSMA with gallium-68 for imaging and lutetium-177 for therapy. This is the example of lutetium-177 PSMA treatment for prostate cancer by Kulkarni et al. In February 2016, the patient has a prostate cancer which has metastasized to various sites, and the PSA is 256.2 nanogram per ml. And after the treatment, which is in October 2016, amazingly, the PSA has dropped to 0, and all the metastasized tumors have gone. And 1 year later, the patient came back for follow-up and no recurrence, PSA remained as 0. Okay, again, Mr. Soma will explain to you in more details about this treatment. In the near future, we might see another product coming up, which is RD131, PSMA 1095. It's also used for prostate cancer. Currently, the study is undergoing a phase 2 clinical trial. And finally, I will talk a little bit about theranostics. Theranostics is a new terminology, stands for therapy and diagnostics. There are multiple ways we can achieve theranostics. It can be divided into indirect methods and direct methods. In the indirect methods, the first approach is known as sister imaging isotopes. For example, RD131 is used for thyroid cancer treatment using the beta radiation. But for imaging purpose, we can replace RD131 with RD123 so that we can eliminate the effects of beta radiation on the tissues. Or we can replace with RD124 and do a PET scan. And for yttrium-90, we can use yttrium-86 for PET scan. Another approach is using another imaging isotopes on the same molecules. For example, yttrium-90 DOTA-TET, used for the treatments of neuroendocrine cancer. When we want to do a whole body imaging, we can replace yttrium-90 with indium-111, and that can allow us to do a SPECT images. And using this indirect method, it will produce a good image qualities. But of course, the method is more expensive because 2 different isotopes are involved, and also the distribution might be different. Whereas in direct methods, we can use additional gamma or positron of the same therapeutic isotopes. To achieve this, we need to have a radioisotopes that can emit both beta and gamma radiation. For example, lutetium-177. Despite the beta radiation, it also emits 208 keV gamma radiation, which is very useful for SPECT imaging. And RD131 as well. It also emits 364 keV gamma radiation, which we can use it for SPECT imaging. And lastly, we can use a secondary brainstorm photons generated by the beta particles. This example is the yttrium treatment. Yttrium is a beta source. It will interact with tissues and generate brainstorm X-ray. And the gamma camera can actually capture the brainstorm X-ray to form the image. So using this approach, it will give us the actual therapeutic distributions, but it might compensate the image quality. For example, in the brainstorm X-ray imaging, the spatial resolution is compensated. In summary, theranostic radionuclides emits both high LET radiation and low LET radiation. High LET radiation, for example, alpha, beta, alpha electrons, is used to kill the tumor cells, whereas the low LET radiation such as gamma and X-ray are used for diagnostic imaging. So that's the end of my presentations. I would like to conclude my presentation by citing this paper, The Future of Nuclear Medicine as an Independent Specialty. The future of nuclear medicine is bright. Nuclear medicine represents a vibrant and viable specialty encompassing molecular imaging and molecular radiotherapy. Nuclear theranostics is the most convincing example of precision medicine. Completely revised board certification and licensing standards are needed. Thank you very much for attention.